I think the physicians created this law because I think they're not quite sure what nurse practitioners do. I think even to this day there's physicians that are not quite sure what nurse practitioners do. I think there's a lot of people who don't know what nurse practitioners do.
We have not completed medical school. We've been trained in a nursing model. We can prescribe, we can order diagnostic tests, and we work in conjunction with all of the members of the healthcare team to provide them with primary care or specialty care, depending upon where we work. And we refer to physicians primarily, should they have something that exceeds our abilities.
I will be working completely independently. The physicians will be there pretty much on the same days that I'm there. But I will have my own panel of patients, which I will be responsible for.
You have somebody who is trained and available to facilitate patient care and be help with rounds, help with education, help with floor duties, help with paperwork. So there's a number of things that they can do that frees me up to do other things.
I think the collaborating agreement gives a binding agreement that allows for them to have definitive physician backup.
It does not stipulate that the patient must be seen every third time by a physician, or that the chart must be reviewed, or that you must meet for 30 minutes on Wednesday to discuss things. It doesn't stipulate any of those things. It simply says these physicians agree to be your collaborator and available should you need them, and have knowledge of everything you're doing.
I think it was more of a security blanket for me as a newly graduated student. But I would say that within 6 months to a year, I really felt like I really didn't need it at that point.
But most of the nurse practitioners I've worked with are not capable of independent practice and don't want to be independent. They like that support environment.
Given our logistics, where the hallways that we work in at the VA and the patient populations that we work with, we don't collaborate on patient care much at all. So I don't find that collaborative agreement with those two physicians changes anything that I do on a daily basis.
Most of the nurse practitioners that I know very rarely have to go to someone and say, what do you do with this? I'm not really sure.
There always will be that possible chance, maybe it's 1%, maybe it's 10% of times where they may encounter something that they're uncomfortable with or unfamiliar with. And I think the collaborating agreement gives them the ability to know they have a physician backing them up. Legally they can call, whereas they'll never be put into a position where if they don't know and there's no one around.
Any practitioner that is worth their weight knows when they don't know something, and they should have the security in their own self to know that.
Most good practitioners, doctors and nurse practitioners and PAs would reach out and ask someone if they were unaware of what the answer was to a problem, but the legal binding agreement provides that to be definitive.
The minimum standard to be a doctor is significantly higher than the minimum standard to be a nurse practitioner. And from a regulatory point of view, it's about protecting the public. The level of independence given to nurse practitioners is going to ultimately not be an intellectual objective decision. It's going to be a political decision. And that political decision will be driven not by how qualified the nurses are, but by the strength of the nursing lobby to overcome the objects of any other lobby that objects, the medical lobby or whatever other lobbies object.
And even now, we've had a little interaction with a couple of senators who said, I get it, Mary, I get it. I know what you do. You're great. You take care of my family. But if I sign on to this legislation, I will have the AMA, the family practice docs, and every physician in my district banging on my door and taking their contributions away. And I don't know if I can handle that. So the physician lobby is big in Pennsylvania. The AMA has lots of money. Physicians make a lot more money than nurse practitioners. And so, politics is generally about power and money.
I am credentialed with Medicare and Aetna. Those are the only two insurances that I can bill for myself directly as the provider. All other insurances I have to bill as the physician being the provider, but me being the what's called an auxiliary provider. And in that case, I get 85% of whatever he gets paid.
I don't know that I understand the logic of paying less for a nurse practitioner, for a mid-level provider providing the same service. And I'm not sure where the 85% comes from.
Since I have my own panel of patients, there's certain quality measures that I'll be graded upon. And as of right now, I will not get a bonus on that. The physicians do, but I don't right now.
We have, the Pennsylvania Coalition has a bill that Senator Vance is going to introduce for full practice authority to follow what's called the consensus model, the national plan for all nurse practitioners to be on par, to practice within their scope and to have the same requirements to practice in each state. Even now, with that coming out, my fear is that physicians are going to pull back and say, well, no, I'm not going to be your collaborator. I'm not signing that piece of paper. I don't want to be your substitute. Take me off. And if that happens, that indeed will stop nurse practitioners from practicing.
I do know of one practitioner a physician who said that they didn't want the responsibility of having a nurse practitioner work with them.
If it passed through Congress and they didn't have a legally binding agreement, I think I would still practice with nurse practitioners, and I would hire the ones that, after an interview process, that I was comfortable with.
I don't know whether it's, the reaction to change or a fear that nurse practitioners are going to take over the turf and the physicians aren't going to have work, or I went to school for so long, I'm better than you, how dare you, or I'm not sure exactly what it is, because there's plenty of work for all of us, plenty.
There's going to be an influx of patients coming into the doctor's office as well. And if they can't hire a physician in primary care, I think the medical students are going less and less into primary care. And so it's going to be harder and harder to find a young doctor as a partner. And if this influx of patients comes all of a sudden, your practice is really increasing in size, then they're a nice option to have.
I think there is going to be a huge influx of patients that will need providers. And the primary care physicians are already overwhelmed and overworked. It's going to put a huge burden on our emergency rooms, which are already overburdened and overworked, because everybody goes to the emergency rooms for primary care now because they can't get in to see a doctor. So let's open up the floodgates. Let everybody get the care they need by whatever practitioner they choose to have it, whether it's a physician, a nurse practitioner, or a PA.